psoriatic arthritis, and also to talk about RWE, real-world experience. Alexis.
Hi, my name is Alexis Ogdie. I'm Associate Professor of Medicine and Epidemiology, and today I'll be talking to you about real-world evidence and registries in psoriatic arthritis. These are my disclosures. I won't be talking about any drugs specifically during this presentation. So one of the reasons that I'm talking about this particular topic is A, I do this kind of work, and second, this has been of great interest to the FDA in recent years. So we've talked a lot about how clinical trials provide one aspect of how a drug works or what are some of the adverse events. But when we really learn about the drug is when it goes into the real world. And so these real world data or real world evidence studies are really important, and the FDA is adding more weight to them when they consider new drug applications and additional evidence that might inform their label down the road. So I just pasted this here. This is from the FDA website itself. And the FDA says that it's using real world data or RWD and real world evidence to monitor post-market safety and adverse events to make regulatory decisions. Additionally, the healthcare community is using these data to support coverage decisions and to develop guidelines and decision support tools in clinical practice. And finally, medical product developers are using these real-world data and real-world evidence to support clinical trial designs. And this might be large trials or pragmatic clinical trials, as well as observational studies to generate innovative new treatment approaches. So as I talk today, I'll talk about some of these different aspects of real-world data, like where do you get real-world data, and some of the ways in which real-world evidence might inform either clinical trial design or outcomes, especially including labeling and potentially how we might think about using the drug in real-world practice. This was all because of an act passed in 2016 called the 20th Century Cures Act. Just wanted to bring this along. When did this become important? Or first of all, I think it's always been important, but it was recognized as more important by the FDA after this act. And this was designed to really accelerate medical product development and bring new innovations to advance faster and more efficiently to patients who need them. And I think this is really the idea that this real world evidence actually brings a lot in terms of how we can care for patients, or adds a lot. So what are some real world data examples? This is from the FDA website. I thought it was nice to use their examples, but I'm going to go through these each in more detail. Electronic health records, claims and billing activities, product and disease registries, patient-generated data, including in-home use settings, and data gathered from other sources that it can inform healthcare, such as mobile devices. So we've talked about some examples of real-world data. How does this data become evidence? So what the FDA means by real-world evidence is that it's the clinical evidence about the usage and or potential risks or benefits of a medical product. And these are derived from these real-world data sources. But this can also include randomized controlled trial data that's been reanalyzed in different ways, pragmatic trials, which we'll talk more about, and observational studies, whether prospective or retrospective. So why is this still important beyond the clinical trials that we see? So when we see clinical trials in psoriatic arthritis, let's say, they have the outcome of ACR20. ACR20 is not really a practical outcome for use in clinical practice. We don't use that. We don't look at these 7 different elements and say, if you responded to these 2, then we apply the next 5. It's not practical. But furthermore, if you look at an ACR20 response in someone who only has one swollen joint, you're really not going to ever you can't achieve a 20% improvement in one joint. So for that reason, the outcome measure alone is not really specific to clinical practice. But in addition, in order to actually achieve an ACR20, you have to have patients coming into the trial that have high enough disease activity that they can actually change that much. So this leads to trials packed with patients that we don't see in clinical practice in general. They represent a very small minority of the patients we generally see. So in 2019, Kurt Lamb and Rick Lories and Vandendorp published this article on the evolution of patients in clinical trials. And I put this box around the swollen and tender joint counts. And here you see that the mean swollen joint count in these studies used to be 14 in period 1, which is the beginning of the biologics area. And then it's still around 13 swollen joints on average in a clinical trial. And as far as tender joints, originally it was 24, 25, but we're still having about 23 swollen joints in these in tender joints in these clinical trials. So if you think about the last time you saw a patient with psoriatic arthritis who had 13 swollen joints and 23, 24 tender joints, we don't see many of that with that high level of disease activity. But that's the type of disease activity you have to have in these trials in order to see differences. So what does this look like in the real world? So these are two different real world cohorts. The first is the PARC data set, which is one I'll tell you more about. It's our longitudinal cohort study at Penn, Utah, NYU, and Cleveland Clinic. And then in addition, we have the Epitopes registry, which I'll also talk more about. And what you see is that among patients switching therapy in both of these studies, the mean swollen joint count was around 3, and the mean tender joint count was around 6. And in Epitopes, the mean swollen joint count was around 3, and the mean tender joint count was around 6 or 7. So you can see that these populations are so very different from the populations enrolled in clinical trials. So this is why real world evidence has so much weight, is that the data from the real world really reflects the patients we see, or ideally it reflects the patients we see. In general, real world populations have lower disease activity, more prior treatments, so they may be more refractory to care to new therapies, and then also more comorbidities, and also likely less adherence because they're not coming into the trial to actually receive the medicines. So it's never really surprising when new drugs that looked fantastic in a clinical trial aren't performing quite as well in clinical practice. So now let's talk about each of the different types of real world data and what kinds of evidence we can draw from these. So first I want to talk about the population-based health studies. So when we talk about population-based, we think about Optum or other administrative data sets that might cover an entire population. So for example, all the patients enrolled in a specific insurance program within the United States would cover across the would cover the United States in general. And so we can generally look at a full population. You have to realize that each population has some differing aspects. So for example, in Optum, we have very small numbers of Medicare patients or Medicaid patients. It's largely commercial insurance covered patients. So we know that that patient population is going to be different from some other patient populations, particularly Medicaid or Medicare when you look at them more broadly. Medicare is another population health data set. So it's going to cover all patients in the United States on Medicare, and they're generally 65 and older or on disability. So again, they're covering a portion of the population. It might not be totally generalizable to the whole population, but at least it's generalizable to that population. Another example is the Health Improvement Network, or THIN, and its cousin, the CPRD, which is the Clinical Practice Research Data Link. These are both electronic medical record databases within the United Kingdom. They cover large, generally representative practices as they're delivering care. So like our Epic, for example, in the United States, they have it across the whole health system, and they can then have a representative section of the health system participating in these data sets. They're just extracting the data, cleaning it, and putting it into usable formats. So electronic health records within our own institutions are not necessarily generalizable in the same way, but there are conglomerates, for example, Optum EMR or Optum EHR data that will have groups of health systems across the country to make it more population-based. So these are some different things you think about when you're choosing one of these data sets. First of all, I might get large numbers, but who am I capturing and who am I not capturing? So I'm going to give some examples of what kinds of data you might expect to get from this. This is a study recently published by So-Young Kim's group, in which she examined hospitalized severe and serious infection after ustekinumab or other biologics. So the goal here was to understand how ustekinumab compared to TNF inhibitors, for example, or IL-17 inhibitors in the risk for infection. So this is an ideal data set for this type of study in some ways, because you're going to get large numbers of patients on these medications. In fact, you can see there were 123,000 patients with psoriasis and or PSA who initiated one of those drugs. And among that, you got 1,500 serious infections. So you can see when someone goes into the hospital in these data sets, in some of these data sets, not all of them. But in this particular data set, I believe this is MarketScan or one of the insurance covered databases. And so you can see generally who's going into the hospital. So we have good capture of outcomes. We know it's related to infection because of the coding for the hospitalization. And they've done validation studies to look at the code for psoriasis and psoriatic arthritis to know or to make sure that we're actually studying the right population. And then with drugs, you actually know that they got the drug because there was a claim paid for the drug. So we have good capture of how often people are taking these drugs. I'm going to come back to some other issues with comparing different drugs to one another in these types of data sets. But one of the nice perks of these databases is that you can get the large numbers needed to compare different therapies. Here's another example of a comparative effectiveness study by Jeff Curtis's group. This is also a recently published paper in RMD Open, and it was comparative effectiveness of biologics and targeted therapies for psoriatic arthritis. And in this case, they compared to TNF inhibitors, and they wanted to know about effectiveness, which was actually kind of a complex outcome in which they based it on adherence, adding or switching a biologic or a phosphodiesterase 4 inhibitor, adding a non-biologic disease-modifying agent, or increasing the biologic dose or PDE4 dose or frequency in glucocorticoid use. So unfortunately, in most of these data sets, you don't get a clinical measure. In fact, you just don't. You don't know for sure that this patient has responded or not. So we have to use these other clues that the patient is doing well. So that's one disadvantage, is you have to kind of make up a rule for that. You can go validate that rule as well. So there's some ability to understand whether or not that's truly capturing it or getting a good sense of that. Persistence is one of those measures we sometimes use for comparative effectiveness. It's kind of a dirty outcome because people may stay on therapy because it's effective. They may stay on it because they can't get access to something else. They may come off of it because they just didn't like it, they had an adverse event, or it didn't work. So you're getting a combined outcome in that case. So in this one, they compared this treatment effectiveness outcome that they defined among the different medication groups. And you can see that compared to a TNF inhibitor, which seemed to be the most effective using their definition, IL-12/23 had a hazard ratio or relative risk of 0.59, and IL-17 had a relative risk of 0.89, although the confidence interval was not significant. And phosphodiesterase 4 was 0.79, and the confidence interval was significant. So it suggests that the TNF inhibitors were more effective in this particular case. So there's a lot of challenges in comparing two active therapies. And this is a particularly problematic in these types of data sets where you don't have any data about the disease activity. I'll tell you that even when you do have the disease activity, it doesn't make it a lot easier. It's just a little bit easier. So one of the reasons is that people get therapies for different reasons, and different therapies are prescribed for different patient populations. Even if you look at the GRAPPA guidelines, you can see that certain therapies might work for certain aspects of the disease, and certain people might not want a given therapy for some reason that they saw on TV that they didn't like, or a family history of some adverse event that they aren't interested in having, or if you think that patient has IBS and you're not sure if it's IBD, you might prescribe one therapy over another. So those things are often not captured because those are the things that we're talking about with the patient. And so the two populations end up looking quite different, but predominantly on the unmeasured things, they look very different. And so we have to think about ways of making those populations more similar. Propensity scores are often used in that way. So I won't go into detail, but there's a lot of methodologic concerns or considerations that you must employ when you use these large administrative databases. And that's where the epidemiologist and the biostatistician are really important in conducting these types of studies. So advantages of these different databases are that there's lots of patients cared for in the real world. In the EMR databases, you have an understanding of what physicians are wanting to prescribe. Sometimes we send in a prescription and the patient never fills it. So the not filled prescription would not end up in the administrative database. And conversely, the physician trying to prescribe something that didn't get picked up or filled wouldn't be present in the administrative database. So in administrative data, you get a sense of the prescriptions filled, and you can understand adherence a little bit by how far between prescriptions someone picked up their next prescription. And then we have international data sets outside of the United States, like Sweden or Norway, for example. They have single health single payer healthcare systems where you can get a lot of data about the patient all in one data set, which is really exciting. In the United States, we're kind of doing much more patchwork when we're putting together data sets from the US. So some other limitations to think about when you're reading these studies of administrative or EMR studies, we're relying on codes. We don't have things directly taken from the patient. We don't have patient-reported outcomes in general. So we have to make sure we validate those codes and we know exactly what we're looking at. In general, we're looking at associations, not causation, so you can never interpret these studies causally. There's a lot of methods we can propose to try to do that, but none of them are perfect. There's observation bias potentially in that patients can be followed more closely for certain things. So I know psoriatic arthritis patients are at increased risk for cardiovascular disease, so I might follow them more closely. There's more misdiagnoses, and because sometimes patients don't come into the doctor to get their diagnosis coded, or the physician forgets to put it in. And finally, there can be missing data because these are open systems. Someone within, especially for EMR data, so someone within our healthcare system where I'm capturing that data might go out of the system to a hospital nearby if they have a myocardial infarction, and that might get completely missed. So these are all important limitations. All right, let's move on to some longitudinal cohort studies. So if you just Google Daphne Gladman, you can probably figure out exactly how relevant and important longitudinal cohort studies are for understanding outcomes in disease. She has really kind of shown all of the things that we can accomplish with these types of studies, and has done a beautiful job developing these studies since the 1970s and following patients forward in time. This is a very expensive and time-consuming, laborious endeavor, but these can be really important. More recent cohort studies are specifically for a goal, or have some specific goal. So in 2014, we started the Psoriatic Arthritis Research Consortium. It's a prospective longitudinal observational study where we start patients with a set of questions and questionnaires, and we do a physical examination, and we document all that, and it goes into one data set. And then we follow them over time, and particularly try to get some new data at the time they're switching therapies. And the idea of this particular pragmatic trial was that we could get a sense of the optimal set of outcome measures for future pragmatic trials. So I'll talk a little bit about that moving forward. Additionally, we wanted to understand phenotypic subsets of patients with PSA and the importance for response to therapy. So this is really the ideal type of data set to get phenotypic subsets, because we're phenotyping patients on patient-reported outcomes, but also a deeply phenotyped physical examination about their psoriasis and disease manifestations and the severity of those manifestations. These are a lot of work. These are work for the patients and for the providers involved. So this is one example of how this might be used. We were aiming to select what are the best outcomes, or which outcomes changed the most after starting therapy. And so here you can see that an unlikely winner was the BASDI, was actually incredibly responsive in patients with psoriatic arthritis, maybe even more so than the RAPID-3. And the PSED was pretty close, actually. So this is a pretty responsive measure as well. So this was one of the goals of this, was to say, what should be the outcome measure in a clinical trial for psoriatic arthritis? I'm going to talk some more about different types of longitudinal observational studies. One of the ones, or there's two that we're getting off the ground that really seek to understand who with psoriasis will develop PSA. And so we're trying to capture the population here so we can observe these things happen and learn more about what's happening along the way, both from a biology standpoint, but also from a predictor standpoint. Can we identify things that are happening here, here, here to let us know that this patient is likely to develop PSA? So the sorecast study recently launched. This is a longitudinal observational cohort study using a mobile device. So speaking of mobile devices, this captures we can use the camera in order to get pictures of the psoriasis and kind of quantify the severity of psoriasis from an image. We can get pictures of dactylitis and measure differences over time. And then we can use the accelerometer and gyroscope to get functional movement and actually have patients do physical exam maneuvers using this app. So it's beta testing right now and is available if any of your patients are interested in patients with psoriasis or PSA at this time, because we're looking at changes over time. We have another new registry we're launching to get the patient voice into care and what's going on in patients' lives around the time that they're switching therapy or starting therapy, what's happening over time as they may develop psoriatic arthritis or other comorbidities. So this is the Forward Psoriasis Registry. This is going to get up and rolling in the next year or so. We're enrolling patients with psoriasis and then doing a direct to patient. There's not much physician involvement except at the very beginning, where they might help quantify body surface area. So this longitudinal observational study will help us understand risk factors for psoriatic arthritis, as well as risk factors for cardiovascular and metabolic outcomes. And we'll enroll the full population of patients with psoriasis who have even mild disease, because we don't capture those patients in a lot of other registries. So the Forward registries in general, there's a SPA registry, RA registry. This is formerly known as the Data Bank for Rheumatic Diseases. There's a lot you can capture there from patients about their experience with the disease and, changes over time, for example, in their weight and how that, and smoking status, and how that may lead to changes in therapy response or what they've experienced from therapy. We can get side effects from therapy from the patient's experience and things that are important to patients. So in addition to Forward, Forward is really a patient-facing registry. There's also Arthritis Power. And this is a great patient-facing registry for patients with inflammatory arthritis and fibromyalgia and other conditions as well, and osteoarthritis. They have an app that is a really great app for using even as a clinician to have them use it and bring in their patient-reported outcomes and track their medication. So there's features in the Arthritis Power registry that are really helpful for patients in terms of managing their disease, but also a great way to do other patient-oriented research. So then we have a different type of registry, which is Core Evitas. There's a lot of going on in the Core Evitas registry in terms of PSA and SPA. In general, registry studies can be used to understand phenotypes, disease states, adverse events, comparative effectiveness, and more. This is an example from the Core Evitas registry in which we examined the different types of phenotypes of patients with psoriatic arthritis. So we examined how many patients had each of these different subsets, where we created subsets based on the number of disease features. And because at every single visit, patients are having a detailed physical examination, we can understand these different subsets and see how diverse and heterogeneous psoriatic arthritis really is. And eventually, hopefully this will help us better understand treatment response in these different subsets as well. So now to finish up, we've talked a lot about observational studies so far. I'm going to talk a little bit about additional studies that would be interventional studies. So pragmatic trials, for example. So the trials that we always think of with drugs are really phase 3 trials, or phase 2 in some cases, phase 2B in some cases. But these are the ones that really inform approval of the drug. So there's preclinical studies with animal models. There's usually a phase 1 study in which they're testing the dosing and just safety in humans. And then phase 2 is really about dosing. Phase 3 is how well does this drug work compared to placebo. That's really about efficacy. Does it work under ideal conditions? And this is how a drug gets approved. But then once the drug is in the real world, we will learn a lot more about the drug and specifically about how it compares to other therapies. So observational studies are how we typically do that, but there's really a role for pragmatic trials, which kind of fit in this space. How do you use this drug in the real world? How does it perform in the real world? Pragmatic trials can be used to inform a clinical or policy decision in real world clinical practice. And participants are generally similar to those receiving care. So really you want the widest open criteria. You also want an endpoint that's important to both patients and clinicians. So I just say that's not the ACR20. The patient and clinician important outcome might be something like a CDAPSA, for example, in psoriatic arthritis, or minimal disease activity, MDA, things that are going to be easier to use in a day-to-day clinical practice and have some component of patient outcomes. There's generally a much more limited scope of data collection. So if you've ever participated in a phase 3 trial, there's a ton of different outcomes captured. Here it's going to be much more drilled down to just what you need so that you're minimizing trial procedures. In many of these cases also, you won't monitor adherence in the same way. You might let it go, just be what it is in the wild, for example, or you might track adherence. So there's a big spectrum of what it is that is a pragmatic trial. And then there's some post-marketing trials. So, for example, we saw the oral surveillance trial was an example, not exactly a pragmatic trial, but it was a little different than a usual phase 3 trial. It was a post-marketing trial for safety. So when the FDA talks about real-world evidence and how it can be used to improve trial design, one of the things that they're interested in is clinical trial simulation. There's a bunch of different words for this. There's also a clinical trial. Emulation is another way of saying this. But ideally, you're taking data from the real world or from an observational study or even from another clinical trial, and then applying some fun statistics to figure out different how much things have changed and then create new comparator arms. So we recently published an example of this. Sarah Weinstein was the first author. And she's a statistician, so the statisticians actually drove a lot of this work. So we took data from the Tacopa trial, which is a intensive versus standard care, and so you had different visit timings, and also different ways of treating. So the standard care would just do whatever they wanted, but then there was a kind of a formulaic way of increasing therapy in the treat to target arm or the intensive management arm. So we took data from that and looked at patients that were initiating etanercept and followed forward in time versus people who were initiating methotrexate and followed forward in time, and then tried to recreate the SEAM trial. Actually, prior to SEAM being published, we did this. And we basically got very similar results, but this shows you just different ways of modeling this. Our results were similar from a relative risk perspective, but actually the confidence intervals were just really wide because we had relatively few patients compared to what they had in the SEAM trial. So we looked at different outcome measures and different ways of estimating these things. So the take-home point here is you can essentially try to conduct a trial before you really conduct the trial so that you understand what's going to happen when you conduct that trial. And there's some circumstances where you could even use some of that modeling to help with healthcare decisions. So this is kind of somewhere I think we're going in the future as we get more and better registry data and longitudinal observational studies to help inform these kinds of designs. All right, so we've talked through a bunch of different real-world data set options and kind of some examples of real-world evidence that you can get from those data sets. So a few different things to think about as we kind of wrap this up. One is that real-world evidence is really important for informing treatment decisions. This is because treatment outcomes and disease subsets in the real world are different than they are in our standard phase 3 clinical trials. So we need more of this. In fact, we need additional pragmatic trials in order to better understand how to use our available therapies in the real world. And finally, the methods matter. So when you're reading some of these papers using observational data sets, make sure to pay close attention to the methods. In general, it's not okay to compare two treatments to each other without implementing some kind of causal method like propensity scores or something similar. So just make sure to pay attention to that. So with that, I will finish and open for questions. Thanks so much for your attention.